I would be now inviting Dr. Jitendra C. from Apollo Hospital, Bangalore, dear friend and colleague, and he will be talking about again one more important domain. So, just like related to the heart, and that is intra-aortic balloon pump. Over to you, Dr. Jitendra.
Thanks, Professor, and good evening, everyone. So after this elaborate discussion on one of the hot topics in CBS questions, that is ROTEM. So now go into another hot topic. You definitely will get a question on IABP. I mean, few exams, there has been a question on IABP. So that is why we'll be going in a little bit detail on this, and mainly we'll be trying to show you to this kind of questions you can expect in the exams in this particular topic. And we'll make it a little interactive so that it will be we'll come to know where we stand before the exams. So another factor you can see yes is about IABP. So though you see, let's say it has been downgraded, but still one of the most common mechanical circulatory device which you use and which have been used in multiple places. It is the most commonest one. So whatever be the level of evidence and recommendation. So today we'll be discussing, and this will be our agenda. So we'll discuss about hardware and the monitor, because sometimes you get questions where they display the monitor screen and ask you what is the finding there. So next we'll discuss about the waveforms, which is the most commonest and commonly asked questions, and little about the physiology. So because if you understand the physiology, it's easy to answer any abnormalities you see on the waveform. And then indications, contraindications, little about the complications. And as said, the errors in timing. That's the most common question which is asked. Little about the evidence, because not only that you
Okay,
can.
so again, I'll repeat the same. So that's what we'll discuss little about the hardware and monitor. So because as I told you, monitor images will be shown in the exam to pick up what is the abnormality seen. So little about that. Then the waveforms and physiology. So how you get those waveforms? What is the physiology behind it? Then the indications and contraindications. Some complications which are common because it's a procedure being done. So any procedure, as you know, EDIC exams, you will definitely be asked about the complications associated with it. And here we have waveforms, and we know there are errors in timing. So that is what is a hot topic in IABP. So errors in timing, you'll have to identify the error in timing and what you do and how you recognized it. That is what they'll be expecting in your exams. Next, little about the evidence, because now it is evidence-based medicine, and any question they ask, they you can expect them to ask about evidence. And next, I'll discuss the most commonly asked questions also. So that is what is the agenda for today's discussion. So, and as I said, we'll keep it interactive because otherwise it'll get very boring. And when you're interacting only, you'll come to know so where you stand. So what are your mistakes you do, and there's no exam. So you can definitely do some mistakes here so that you will not be repeating it in your subsequent exams. Okay. So this is the console, how it looks. So I'll not go into details of this. This is how it looks on the back of it. You have a helium tank there. You have some fibers running there. So this is how it looks. And you have a console and you have a display there. And next to the display, you have a interface where you'll be using multiple buttons to make some adjustments in your settings. Okay, so this is how it is placed in a 3D image. So this is how your IABP balloon, the tip of the IABP balloon. And where should it be placed? Anyone who wants to take the answer? Where should the IABP balloon be placed? What is the optimal position for the IABP balloon? Anyways, I'll be discussing it. Okay. So this is how it is placed. So it will be just 2 to 3 centimeter distal to the offset of your left subclavian artery. That is where it is should be positioned. And I'll be discussing little later. So this is how it looks in the real time. So this is the arch of aorta, descending aorta where your balloon is.
Dr. Jitendra, if you can make it in
Yes,
the
sir.
Zoom, like your
Oh, sorry,
slide
sir.
is, yeah,
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 yeah.
sorry, sir. Okay, yeah, now it is better. So this is the console's picture, the display picture. So the top one is the monitor of your console. So the top green line is your ECG, and you get the heart rate from the ECG. Next, you have your arterial waveform, and next below that arterial waveform, the one in yellow is your arterial waveform. It can be in different colors, that doesn't matter. So next below that in blue is your IABP inflation waveform. So the balloon pressure, what is the pressure in the balloon? That is what will be displayed in that. Coming to the interface, in the interface, you have various modes which are there. You have the trigger settings, the frequency, the augmentation, the various things which are there on your console. So this is how it will be looking on your. So you can get an image of this also. They may put a display of this and ask you what is the trace. Okay, so this is, and everybody can see this is a 1:1 augmentation. So I'll tell you what this 1:1 means and all. And next is, you can see the pointer here. So this is the timing. So you can set your inflation, deflation using these buttons here. And this is your augmentations. Here you can see there is complete LED. All the LEDs are glowing here. So that means there's 100% augmentation. And what is the ratio for your augmentation is 1:1, 1:2, 1:3. And from the picture, that is also commonly asked. I mean, no need to get frightened when they say it is a question on IABP. Sometimes they keep it very simple, not to worry much about it. They may not ask you about the timing or interpret your waveform. They may just simply ask you, so what is the augmentation in this particular picture? So what is augmentation? Anybody wants to tell? So you can write it in your chat box. So this is 1:1 augmentation. You can see every wave there is augmentation. So that is 1:1. I'll show you. I mean, and another thing to remember is whenever there is a IABP waveform, to interpret the waveform, you require at least a 1:2 augmentation. You can't interpret your IABP waveform. I mean, you can't explain what is happening with your end diastolic pressure, what is happening with your diastolic augmentation. You can't be able to comment on it unless you have a unassisted wave. So you should have an assisted wave and unassisted wave. Only then you can tell what is the effect of your IABP. So usually if they're asking you what is the effect of this, then they'll give you at least a 1:2 augmentation. You can't interpret it on a 1:1 augmentation. Okay. So these are the various buttons and display what you see on the thing. Okay, now coming to the thing. So this is how your 1:2 will look. So you have a unassisted waveform. This is a normal arterial trace. You have a upstroke, you have a peak, then you get a dichrotic notch, and then you comes to the diastole. So next is another waveform. Here you see there is some changes in the waveform. That is because your IABP balloon is inflated here. And this is a assisted waveform. See, when there is assistance happening, so your IABP is help the heart. So with that, what is happening? You are having a augmented diastolic pressure. So you see that the diastolic pressure goes high. This is an augmented diastolic pressure after your balloon inflation. And next you come to a lower pressure than the previous waveform. This is your assisted diastolic pressure. So your diastolic pressure comes down after the assistance which has happened. So your inflated balloon helps in increasing the diastolic pressure, and then your assisted diastolic end diastolic pressure comes down, which makes the heart to function better because the afterload is coming down. And apart from that, you also see that the assisted systolic pressure comes next. So that is less than your unassisted systolic pressure. So as you see further waveforms, you will be seeing it. And so what is this augmentation? This is a 1:2 augmentation. You can see this 1:2 augmentation. That is every alternate beat is being assisted. So this is your unassisted, next comes assisted, next the unassisted, next assisted. So like that it comes. Okay. So you require at least a 1:2 augmentation to interpret. In other parts, helium tank. So, what are the commonly used gas is helium. What are other gas you can use for IABP inflation? And they may ask you questions on why helium also. So helium, we know, is a less viscous gas. It is so because it is less viscous, it can easily inflate and deflate. So say somebody's heart rate is 100, so within less than a second, it should inflate and deflate. So that fast happens only when the gas is less dense. So that is one of the reasons why helium is used. So other than that, so it is a very absorbable gas. So by chance, if there is a balloon rupture or leak of helium, so that will get absorbed. So if it doesn't get absorbed, what happens? You'll have air embolism and it will lead to complications. So to avoid that, we use helium. The other gas which can be used, which can sometimes be asked in exams, is you can use carbon dioxide also. Okay. So these are two gases which can be used in your IABP apparatus. So this is the magnification of the waveform. So you will be seeing an arterial trace and you will be seeing a balloon inflation. This red color is your arterial trace, and you can see the gray color underneath your red color trace. This gray color is an unassisted normal arterial waveform. Okay, so here is a dichrotic notch, and when your patient is being on IABP, you would have timed it to in such a way that your balloon will inflate at the dichrotic notch. Okay, so there is increase in your this increase in your systolic peak. So this is your diastolic augmentation. This is the augmentation which has happened because of your IABP waveform, and beneath that, for your to help you out, so you can see that the balloon is also inflating there. Okay, so these two are the waveforms which we'll be seeing on the console. Okay, it will not be seeing on the patient monitor. You'll be seeing this on the console, but the arterial trace can be seen on the monitor, on the patient monitor also if you're using a arterial line. Okay, so this is how it looks. Okay, what is this entire time frame? This entire time frame is the period of your balloon inflation. So balloon inflation, upstroke, it becomes a plateau, the balloon pressure becomes plateau, and there's a downstroke when there is deflation. Again, you'll have a pause for some time, and again another inflation. Okay. So this is with respect to the balloon waveform. So this is pressure versus time. So in pressure, you see the balloon is getting inflated and the pressure in the balloon is going high. And you'll see a balloon overshoot, balloon inflation overshoot. It will go slightly high and come back. Let's say it is just like a ventilator waveform, which my subsequent speaker will be speaking to. So this is like your peak pressure on the ventilator waveform, and this is your P flat on the ventilator waveform. So it will initially shoot and then become a balance. and it will become a flat thing, and then it goes down when the balloon is deflating. So this is balloon rapid inflation and deflation. You have a overshoot and equalization plateau. So just like our ventilator waveform. Okay. So these are the various parts of the arterial waveform. So what all you are seeing? So top one is your ECG. So usually commonly used trigger is your ECG. So usually we time it. I mean, you set a trigger. We will see what a trigger is. The trigger is what is initiating a inflation and a deflation. Okay, what is initiating a inflation is a trigger. The commonly set trigger is your ECG waveform. So where does your inflation happen? It will usually happen at the peak of your T wave. You can all see at the T wave, you can see there is inflation which is happening. And at the peak of R wave, that is just before your systole. So that is when your deflation happens. So just before your peak of R wave or just before your systole, you have a deflation because the heart should pump out blood. Okay, so inflation at the onset of diastole. So you can see it as a sharp V wave. So I told you with respect to arterial trace, it will coincide with the dicrotic notch, your inflation. Whereas with respect to your ECG, it will coincide with the T wave. Okay, at the middle of your T wave. So that is when your inflation happens. Okay, so we'll read what is the physiology in the subsequent slides. This is just to show you the location of the inflation with respect to your ECG trace. Okay, inflation happens at your T wave and deflation happens at your just before your R wave. So that is when after R wave you will be having a systole. So that is when your deflation happens. So occurs at the end of diastole before systole, resulting in reduction of iron. I'll tell you what are the parameters or the hemodynamic effects of these. Okay. And another point you should remember is these things which are there, the A, B, C, D, E, F. Sometimes they may ask you to interpret this, or they may tell you what is happening with the end diastolic pressure. So you should know what end diastolic pressure is. So what is A? A is one complete cardiac cycle. So it's from the time of deflation to the time of inflation up to the point E. From B to E is a one complete cardiac cycle. So where the augmentation has happened. So that is your one cardiac cycle. B is your unassisted systolic pressure. Sorry, unassisted end diastolic pressure. So before your waveform gets supported, that is before your balloon gets inflated, you get the previous waveform and the base, the diastolic pressure is your unassisted end diastolic pressure. Unassisted end diastolic pressure. So the subsequent one which comes at E is your assisted end diastolic pressure. Okay. So after the assistance, you see that the diastolic pressure goes down. Okay. So before that, it is high. So you see the end diastolic pressure going down. So this is assisted end diastolic pressure. This is unassisted end diastolic pressure, which is little higher. Next coming to C is your unassisted systolic pressure. So here there is no assistance from the balloon. The balloon is not yet inflated. So this is your unassisted systolic pressure at C. So D comes your diastolic augmentation. This is the amount of augmentation which has happened. So the balloon is inflated at this dicrotic notch and the augmentation has happened. And you see that is gone slightly above your unassisted systolic pressure. Correct. So this is what is the finding you see. And finally comes your E, which is your reduced end diastolic pressure. And next is your F. That is your reduced systolic pressure. This F, sorry, there is no marking here. So this is your F, which is your reduced systolic pressure, which is seen in your assisted. So, okay, in an assisted waveform, you see the systolic pressure goes down. Okay, so these are the parameters. So remember these terms. So B is your unassisted systolic pressure. Sorry, unassisted diastolic pressure, end diastolic pressure. C is your unassisted systolic pressure. D is your diastolic augmentation. E is your assisted end diastolic pressure. And F is your assisted end systolic pressure, which is less than the unassisted one. Okay. So any doubts? You can stop me at that point, or I'll be repeating these terms again and again so that you will get it registered. Okay. So no need to worry about it. So now we saw the waveform, how it happens. We saw the console. We saw the various parameters which are there on the console, how we set a console, and what parameters are there on a waveform. We saw the ECG correlation of your IABP waveform. We saw arterial trace and the IABP waveform. So now we'll see the various settings which can be made on the ventilator, because this will be asked in an exam. They say they'll show you the waveform. They'll ask you to interpret the waveform, and they'll ask you what should you do with the waveform. So you should know these terminologies. So you can see on the console, you have various settings which you can make. So what are the one is you can move, there is something known as auto mode and a semi-auto mode. You can know by it. So auto mode is completely done by the machine itself. Semi-auto is you'll give some input and machine will do the rest. So other than that, you have something called standby, start. So these are there on the thing. Apart from that, most important thing that you should know is your trigger. So what are the triggers? I told you what is the trigger. Trigger is one which will start the IABP or it will start the inflation in the IABP balloon. So the common ones are your ECG. Next is pressure. You have a pacemaker. Next to only arterial pacemaker. Next you have something called internal mode, which is like a default mode. So I'll tell you when to use these. What are the advantages of these? Next, so based on the source, you can set what is the say ECG. You can select which lead to select. The pressure, you can time your pressure. So the thresholds, all of this. Next is something called as IABP frequency. So at what frequency are you supporting the heartbeat? So every beat you support, it is 1:1 frequency. Every alternate you support, it is 1:2. Every third beat you support, it is 1:3. So we would have all seen this. So just a revision, that's all. Okay. And then next comes the amount of augmentation. So you can see in this, there are 10 LED lights here. So bottom one is, it is 10% increment up to the top. So every LED light increases, you increase one, it will increase and maximum it goes up to 100%. So 10% for each LED light. So there are 10 steps here. So maximum is 100%, least is 10%. So you can increase or decrease the amount of augmentation, means amount of support which you are providing to the patient. So usually we keep the augmentation 100%. And usually when we are weaning off, we'll usually change the frequency than reducing the augmentation. So if there is any abnormality in the timing of your inflation deflation, so you have an option on the console, on the interface of the console, so you can change the timing of it. Here you can see inflation, deflation. When inflation, you can increase or decrease it. Deflation, you can increase or decrease it. So these are common settings which are there. You should know these terminologies. Okay, now coming to the triggers proper. So I told you the commonly used one is the ECG trigger. So you have a ECG waveform. From the ECG waveform, it will pick. I told you. So it is a preferred and the most reliable one. R triggers the deflation. So coming from the starting PQR, so in the R it will trigger the deflation. And T triggers inflation. So I told you inflation happens at the middle of the T wave and deflation happens just at the R wave or just before the R wave. So if there are any arrhythmias, what to do? So there are some newer consoles which will go ahead even with arrhythmias. So even if there are significant arrhythmias, it can go out. If the patient develops a AF, yes, irregular, what to do? So no need to worry. Some newer consoles have AF trigger also. So if there's AF on your patient, if the patient was sinus tachycardia till now or sinus rhythm till now, suddenly develops AF or some tachyarrhythmia, no need to panic about it. You can change either you can change to other triggers like pressure trigger, or you can change to a trigger called AF trigger, which is there in some of the newer machines. So it will just support the patient at every R wave. Say rate is 180. So every R wave, it will start supporting the patient. Okay, no need to panic about it. Even if the rhythm is abnormal, so it will still support the patient. So next commonly used trigger is a pressure trigger. I told you if there are some tachyarrhythmias, sometimes you can change the trigger to pressure trigger and you can time it there. So whenever there is poor ECG quality, that is when we'll consider. So sometimes you have very sweaty chest, hairy chest, or your ECGs are not picking. There's some significant pericardial effusion. The amplitudes are very, very small. So that is when you'll consider using your pressure trigger. So this is one of the things. Most commonly, whenever the ECG trigger is not working, that is when you go with the pressure trigger. So where do we trigger? I told you dicrotic notch is a trigger for inflation, and point just before systolic upstroke triggers the deflation. So at the dicrotic notch, you'll have an inflation, and just before the systolic upstroke, okay, just before the arterial trace upstroke, we saw that no end diastole, unassisted end diastole. So that is when you'll see that there is a deflation. So when do we commonly use it? During CPR. So what happens during CPR? We know there is no rhythm during cardiac arrest. So you can't, your IABP can't rely on the ECG waveform. So that time what you'll do, you'll change the trigger to pressure and you'll continue. So whenever you're doing CPR, you have arterial trace. So it is producing a dicrotic notch. So the IABP will continue to function with the pressure as the trigger. If it was ECG, you can change it to pressure trigger and continue your CPR. No need to panic about it. So next comes something called as internal trigger. So your ECG is also not working, your arterial trace is not great. Then you can put it to a baseline default mode called internal trigger. So here asynchronous rate without physiologic triggering, without any trigger, it will continue to give a trigger. Like say when it happens, say when your patient has a asystole. So there's asystole. What to do? You have a IABP machine. You are still preparing to start CPR. So that time you can put into internal trigger mode. It will only set. Usually it will be set at a rate of 80. So 80 beats will be supported. 80 times the balloon will inflate and deflate. So this can also happen when your patient is on a cardiopulmonary bypass. We all know there is a non-pulsatile flow during cardiopulmonary bypass. So during that time also, during asystole or during CPP, when your ECG and arterial trace is not great, so then you will put this patient on internal trigger and your patient will be supported by IABP with a basic internal rate. Usually it will be at a rate of around 80 beats per minute. So your patient has a pacemaker. So you have a pacemaker as a spike also. I mean, pacemaker as a trigger also. So nothing, sir. We say you have somebody who's on IABP is coming by ambulance. You don't have a doctor there. So, but you can in that time. So you don't know the person who's there, a paramedical who's coming accompanying with the patient, or the doctor who's accompanying doesn't have any idea about the IABP. Then you can put this patient on auto mode and leave. So that will take care of the trigger part. Okay, so these are the commonly used triggers. I told you ECG trigger is the most commonest. Next commonest is pressure trigger, mainly used when ECG is not reliable or during CPR. Internal trigger when there is asystole or and the patient is on cardiopulmonary bypass. Pacemaker trigger when the patient is on a pacemaker. Auto mode when somebody with less knowledge about IABP is manipulating or handling the machine, then you can put them on auto mode. Okay. Or when your patient is in cardiac arrest, you don't know what to do, just put it on auto mode, it will take care. Okay. So we saw the various triggers. Next, I told you is level of augmentation. I told you we have those LED lights, which are there in 10 steps. 10 LED lights are there. So the least is 10%. The maximum is 100%. Usually, if you see, it will be kept in 100% because we want to give maximum augmentation. That is how much is the balloon getting inflated. So balloon should inflate not more than 90%. At least 90% should be inflated. So that why is this important? It is important because the amount of balloon inflation is what is pushing the blood. The blood is getting displaced. So that is the blood which is coming back and doing the coronary circulation. That is what is helping your heart function. That is what is reducing your IABP. So all this depends upon how much is the balloon getting inflated. So that is the level of augmentation. I told you usually we keep it at maximum 100%. So by default, IABP augments every cycle. So that is what is default when a patient is very sick. So that is what we keep at 1:1 augmentation. How do I wean off my patient? So what do we do once the patient's condition is better, hemodynamics is better, his inotropes are stable or coming down? That is when we think about weaning the patient. So then we do 1:1, we reduce it to 1:2. So that is every alternate beat is supported. Instead of every beat supporting, you support every alternate beat. The patient is doing good on that. Hemodynamics are stable, no increase in inotropes. You can change it to 1:3. And usually after 1:3, so if the patient is stable, that is when we think about removing the IABP. So timings and adjustments should be done in 1:1. That's what I told you. Say you started your patient on 1:1. So I should know what is happening with the inflation, deflation. How do I do? So start with 1:1, change to 1:2. I told you can appreciate what is happening with the hemodynamics and what is happening with the inflation and deflation only if you put it into 1:2. So change it to 1:2, adjust your timings, and then put back again to 1:1. And after that, when you're trying to wean, you can again change back to 1:2. Whenever you have any doubt about inflation, deflation, whether the timings are right or not, change the mode, change the augmentation to 1:2, see the adjustments, see the waveforms. After seeing that, again put back to 1:1. Okay, that is what you're supposed to do. Okay. So what does it mean? So, sir, you said, what is this augmentation coming down on augmentation? That means, so when the support from the machine is less, even then, if the coronary perfusion is good and the heart is doing good, that means that with minimal support also, the heart is doing good. 1:3 is the least support. In that, if he is doing good, that means that the patient can be weaned off from the IABP. So that is what it means. Okay. So a little more about the balloon. Sometimes they may ask you, how do you decide? So this may not be asked you in the CBS part. Sometimes in the CCS part, somebody says this patient is in cardiogenic shock or heart failure, may require a circulatory support device. If you're commenting on IABP, then they may ask you, how do you decide on the IABP balloon size? The balloon size depends upon the patient's height. Okay, keep it in mind, not the weight of the patient, it's the height of the patient. If the patient's height is less than 152 centimeters, you use a 30 cc balloon. If it is 152 to 162 centimeters, it's a 40 cc balloon. If it is 162 to 183 centimeters or anything beyond 162 centimeters, it is 50 cc balloon. Okay, so use this. And why this size is important is because the anatomy, we should place the balloon between after the branching of the left subclavian and before the renal arteries. So that is what. And this length depends upon the height of the person. And that is why this size of the balloon. Okay, so that is why. So you should miss the left subclavian and you should not obstruct the renal arteries. So that is the logic behind it. That is why this balloon capacities. Okay. Now coming to how do I know the position? So that is usually done by radiography. You will be doing it in a cath lab. So you do a fluoroscopy and confirm it. Or after coming in the ICU, you can do a chest X-ray and confirm it. So in this two X-rays, in both the X-rays, it is not in ideal position. Usually the tip should be at the level of the carina, just below the carina. You can see here in the first image here, the IABP balloon has gone beyond the carina. So carina is here, it's gone beyond. So it is gone to inside, so it will be obstructing your left subclavian artery. So you monitor the left subclavian pulse. So you'll see that the pulse is very feeble or absent. So that is because your LFPP balloon is obstructing the left subclavian artery. The ideal position I told you should be at the 2 to 3 centimeter from the at the level of the carina. Okay, just in and around the carina. Whereas in the subsequent, in the second picture, the carina is here, but your balloon is too low. So here, so it is too low. So you should push it inside. So it may be obstructing your renal arteries. Okay, so in both the pictures, the balloon is not in position. When first picture, it is very too ahead. In the second picture, it is too distal. So you should push it little more inside. Okay. So this can also be asked in your exam. So this is the X-ray, a comment on the things. Other than this, in this image, it's a radiology ED question. Okay, so there are other hardwares. I'll not be commenting on the other hardwares, but with respect to IABP, so the first one is two inside, the second one it is two outside. So you should adjust the position. This may be asked in your exam. The tip should be at the level of the carina. Okay. So now coming to the physiology. So we saw the hardware part, we saw the how to time it, how to trigger it, how to augment it, how to wean off all those technical terms we saw. Now coming to the physiological benefits. Okay, during your so again this may be or may not be asked in your CBS. So CBS it can be part of your what are the physiological benefits. Sometimes they can be asking you in the CCS also. So you started your patient IABP, they may ask you about the physiological benefits. So what are the benefits of IABP? We all know it improves the coronary circulation. So reduction in LV stress and reduction in LV afterload after deflation at the systole. So there is sudden giveaway. So that will facilitate the LV. The workload suddenly comes down. That will facilitate the heart to work. They facilitate the LV to work mainly. So increase in LV ejection fraction because the afterload comes down. The LV ejection fraction becomes better. So cardiac output, how much does it increase? It increases up to 0.5 to 1 liter per minute or up to 30%. So there is increase in the heart rate, increase in the cardiac output from the baseline, it increases by 30%, or it increases in overall 0.5 to 1 liter per minute. This will be asked when you're asked about mechanical circulatory support devices. Okay, each device you should know what is the increment in the cardiac output that will happen when you use that particular device. So they may ask you a question on Starling's curve also. What happens? Obviously, right side movement of the curve means the LV is becoming bad. So obviously, you're putting IABP to facilitate the LV. So you can blindly say it is leftward shift. Apart from what will happen, there is systolic unloading. And I told you, even the peripheral blood flow improves. When the balloon inflates and deflates, there is distal pushing of the blood that will improve your peripheral perfusion also. This is not very significant, but this is what they'll be asking. Another important question they'll ask you is, what is the effect on RV? So the answer is, there is no direct effect on the RV, but there is indirectly it will help. So because you're facilitating the LV, so there is some offload on the struggling RV. So some effect, some influence is there, or some help is there for RV also, but mainly it is for the LV support. Okay. So again, because it's a procedure, it's a external device, extracorporeal device. So they will be asking about the indications. You can broadly classify them to two categories of it. So one is for the cardiac failure to support your LV, like following an MI or intraoperative injury. A second one is to match your LV is okay, but there is demand supply. There's mismatch of your oxygen supply demand, and there's a significant amount of ischemic zone to reduce your ischemic zone to preserve the myocardium. So one is the myocardium is damaged and you want to support it, it is not able to function like in heart failure. The other one is to help or improve the supply demand, like in it is improving the coronary perfusion, so that will improve your oxygen supply. So these are two categories. The other, you can subdivide them. These are the other indications. I'll not go into detail of it. Broadly, you can classify into one supporting the mechanical function of the heart. The other one is improving the oxygen supply demand balance. Okay. Now coming to the contraindication, as I told you, any procedure, they'll ask you about the contraindications. You should know the absolute contraindications. If they're asking you the question, these four should definitely be there because they'll be getting you the maximum marks. So what are the absolute contraindications? So aortic regurgitation, dissecting aortic aneurysm, large AV shunt, and patients with chronic end-stage heart disease with you are not expecting any recovery to happen, then you may not be putting this patient on contraindications. We will not be starting him on IABP. So you should definitely know aortic regurgitation and aortic dissection. So relative contraindications like peripheral vascular disease, aortic aneurysm, severe non-cardiac systemic disease, massive trauma. These are relative contraindications, but definitely they'll ask you about the absolute contraindications. Okay. So they may ask you, so this patient has a FEMPOP in place or peripheral vascular disease. What do? You can try the other vessels. Okay. You can try the brachial, you can try the internal iliac. So like options like that are there. Okay. So again, and any procedure, so you will, whenever they ask you the complications, we always tell in our course. So it is always better you classify them, you divide them, you categorize them, and you can categorize them during any procedure for that matter. So it is intubation, ICD, defibrillation, any procedure for that matter. So you classify them into you categorize them. So during insertion, during its use, and during removal. So it will make your job easy, and you'll get two answers for each. So that will cover most of your answers. Okay, you will not be missing anything. So if you blindly answer, so you may miss certain important points. So if you subdivide them, so it is easy for you to answer, and you'll get multiple answers. So coming to the complications during insertion. So what one, it can be distal peripheral, bad peripheral vascular disease. You may not be able to canalize it. It is very, very common because it's a pretty big cannula will be inserting, a pretty big sheath will be there. The balloon should go. If the vessels are damaged, there is significant sclerosis, then you will not be able to do. That is the most common complication you will be seeing. Sometimes if you injure the aorta, it can cause aortic dissection. Malposition, I have told you, very, very important, can lead to it. Malposition can happen anytime. Okay, during insertion or during use also it can happen. So you should be very, very careful. You can tell that in both the cases. Axial femoral vein cannulation can also happen when you are not sure about the structure. So next, during the use, I told you it is a extra, when it's a external device in the patient's body. Sometimes people use anticoagulation, but most of the centers they're not using anticoagulation. There is high risk of thrombosis. So peripheral embolization is possible. Once the thrombosis form, it can get dislodged. Incorrect position. I told you, if the patient moves his head, flexes his leg, or you extremely flex your patient's upper body, that can lead to dislodgement or movement of the balloon. So you should be very, very careful not to move much, not to usually keep him well sedated and restrain the leg so that he doesn't move much. Infection, if you're handling it in an aseptic way, you will get. So high risk of infection. If you're not following strict asepsis, then there is high risk of infection. Perforation of the balloon can happen, but very, very rare. So balloon rupture, balloon gas embolization, hemolysis and thrombocytopenia is a very, very common complication. Some amount of hemolysis happens because the balloon is causing trauma and it will cause damage to the RBCs and the platelets. So, and thrombosis is there. So all of this can lead to some drop in HB, some drop in platelet count. Peripheral neuropathy can happen, and timing error. I told you when you're using it, so timing error can happen anytime. So always check. How do you check? You put the patient, if he's on 1:1, change to 1:2, check the timing, and again change back to 1:1. After removal, what can happen? Yes, obviously you punctured a big vessel, removed a big catheter, so there is risk of bleeding. So complete occlusion, 20 minutes. Pseudoaneurysm can happen, fistula can happen. Sometimes your balloon can get entrapped. You kept the balloon for a longer time, some calcification has happened. So there is already a calcified vessel. So some thrombosis can happen, atherosclerosis can happen. That can trap the balloon. That is also very, very rare complication, but that can happen. So always whenever they ask you, so about the complications, time them. Okay, so during insertion, during use, during removal. Say for tracheostomy also, say during tracheostomy, after tracheostomy, and post decannulation. So like that, you can time them and you'll get multiple answers for that. So that will you'll be covering most of the options which the examiner has. Okay. Now coming to the part, so we have discussed the theory part. So now we'll go into what are the commonly asked questions. I told you the commonest questions which are asked about IABP are timing of your inflation and deflation. So this is, again, I've told you, I've already repeated this in the previous slides. Again, I'll be reinforcing it here. So what is this augmentation? I told you if they have asked you about the IABP waveform, to interpret IABP waveform, it should be in 1:2 augmentation at least. Okay, you can't do the interpretation on a 1:1 augmentation. So I told you where should the inflation happen? The inflation should happen on the, so this is arterial trace. So where should the inflation happen? The inflation should happen at the dichrotic notch. So you'll see a sharp V there. So that means that the augmentation is absolutely fine. After that, what happens? You'll reach the diastolic augmentation, that is peak. That will be very higher than your previous unassisted systole. Okay, so this is your unassisted systole. This is also unassisted systole. So your diastolic augmentation will be more than your unassisted systole. So that what is the help of that? That is what is doing your coronary perfusion. That is what is improving your coronary perfusion. So that is the thing. After that, you see the balloon gets deflated and you see that the pressure is not falling straight down. It is going slowly and coming down. It is not a straight line down. It is slightly steep. It is going like a peak like that. Okay, so you should remember this because once it goes down straight, that means there is some error in that. I'll be discussing the subsequent slides. So after that, what happens? There is gradual decrease in the pressure and then you reach a bottom, and that is nothing but, I told you, your assisted end diastolic pressure. So that is what is decreasing your patient's afterload, or that is what is reducing the patient's myocardial oxygen requirement. Okay, so and you can see this point is less than the previous unassisted end diastolic pressure. So this is the assisted end diastolic pressure. This is the unassisted end diastolic pressure. You can see that the diastolic, you will also have seen in your waveform, correct? In arterial waveform, you see that the arterial pressure before IABP and after IABP, you see that the diastolic pressure is significantly low. You would be thinking, is it some sepsis or vasodilatation? That is not the answer. The answer here is because of your balloon getting deflated, you see that the end diastolic pressure comes down below the unassisted. Okay, so you see there is diastolic augmentation which goes above the unassisted systole. And you see the end diastolic pressure goes below the unassisted end diastolic pressure. These are the two common things you should always remember. And what is the purpose of this? Diastolic augmentation is one which increases the coronary perfusion, and your diastolic pressure going down is one. When the balloon deflates is one which will reduce the afterload or reduce the oxygen demand by the heart. And next is your again unassisted beat. So again you get your assisted systole. So again, so this is how it continues. Okay, I've already described this. So what should be the significant drop? I told you the diastolic augmentation at least should be 15 to 20 millimeters, and your end diastolic pressure should drop at least by 5 millimeters. So this is the most important one. Okay. So anybody now starts the questions. So we'll keep it interactive. So anybody, see, I put the normal graph also for your easy understanding. So anybody wants to answer this? You can put it in the chat box. So am I seeing the notch? I'm not seeing the notch. Okay. So what is this? So, and you are seeing, so there is this unassisted systole, and immediately after unassisted systole, you're seeing there is augmentation. So, what is it? Anybody? I can't see any answers. Yeah. So, already there, few questions we have. So, this is early inflation, right? So, you can see before the dichrotic notch itself, the augmentation has happened. Okay. So, see, this is what it is. So, next comes, this is first thing we will be asked in your CBS question. So, what is the abnormality? So, it is early inflation. Okay. So what next comes, how do you say it is early inflation? What are the parameters which are happening? So mainly they're asking you about what is happening to diastolic augmentation, and they're asking you what is happening to the aortic and diastolic pressure. So that is what they'll be asking. And because of this, what is happening? So what are the hemodynamic effects? So these are the two things. First, they'll ask you to identify the timing abnormality. Next, they'll ask you what are the hemodynamic effects of it. Okay, so what is happening here? So you see that the IABP is getting inflated even before the dichrotic notch. So what is happening here? So when the uh, so this will lead to premature closure of the aortic valve. So what is happening? The heart is made to work against the closed aortic valve. So this will lead to aortic regurgitation, increase in afterload, increase in myocardial oxygen demand. So all of these happens. Okay. So what do you do? They'll ask you, what do you do for this? So what do? You'll go to the console, put it in 1:2 mode, and you, time the inflation. Okay, you make it to time when you bring it to inflate a little later. Okay, you adjust the time. I've shown you on the console how to do it. Okay. So next one. So anybody wants to take this? You can see there's a dichrotic notch. You can see after that there is some wave coming. You can see that the diastolic augmentation is not significant at all. And you can see assisted systole is less. So what is then? I think I have got some answers. It is late inflation. Absolutely right. So you can see after the dichrotic notch, after some delay, there has been some inflation. So yes, the answer is late inflation. So what do you see because of that? So yes, what do you see? You don't get the sharp V, correct? You're supposed to get a sharp V at the dichrotic notch, but here you're getting it little late and it is not that sharp also. So what happens because that I told you the diastolic augmentation down is come down. So I told you what is the importance of diastolic augmentation? I told you diastolic augmentation is one which will lead to coronary perfusion. Because the diastolic augmentation is less, you can see the unassisted systolic pressure and diastolic augmentation is less than the unassisted systolic pressure. So what will happen? The coronary perfusion will be very, very less. Okay, so how do you do? Now again adjust the timing. So ask the balloon to inflate little early. That is what you will be doing. So next, anybody wants to take this? Yes, anybody? So somebody said normal. No, normal is one in the blue, which is there. Somebody says early deflation, steep slope. Yes, see early deflation. So it was supposed to not slope like that. It was supposed to slope little slowly, but it is slow. So what is happening here? It is early deflation. So the balloon is getting deflated too early. Okay, so that means It was supposed to provide some support. Before it would complete its support, it has already got deflated. So what is happening because of that? So it will lead to you don't get significant diastolic augmentation. So it is not very effective. So the afterload reduction doesn't happen. So what is happening? Even before the LV starts pumping the blood, it has already got deflated. So what was it supposed to do? It was supposed to get deflated at the start of systole. Okay, but it's got deflated before that. But now the LV has to pump again the same afterload. So there is no reduction in the afterload. So what is happening before because of that? There is increased myocardial oxygen demand. So what do? Again, I time it. So I time it and bring it down to that position. If you can't time it, you are very lazy to do that. You can just put it on auto mode. It will only optimize it. Okay. Last one with the timing. So what is left behind? So this is the thing. What is happening here? So anybody? So this is late deflation. You can see very late it is getting deflated. I mean, it is easy. So obviously there are only 4 errors in timing. So I finished 3 of them. So it is easy. But in the exam, you should appreciate the waveform. Only then you'll come to know. Okay, you will not be having a normal waveform there. You will only have this waveform and you will be having 1:2 augmentation. So you should see what is happening here. Okay. So this is how the waveform looks. Prolonged rate of rise of assisted systole. So slowly it will rise. Okay. And you see that the assisted end diastolic pressure is almost the same. It is not reduced. Correct. I told you it should get reduced because the heart should get support. So because of that, what is happening? The heart is doing more work. Okay. So how do you adjust it? So you will adjust the timing. Okay. So this is how it is done. Okay. We finished the timing errors. So we have already discussed the weaning. I'll not repeat it again. Okay. So now let us go to the most important part, evidence. Okay, in the CBS itself, say they may ask you first question, comment on the IABP waveform, how do you adjust it? Next question can be, what is the evidence for it? So you will definitely be asked about evidence. So in any therapy, any mechanical circulatory support devices which you use in cardiology, everything they'll ask you about the evidence. So the common evidence which we have is, you all know about it, is IABP Shock 1 and Shock 2 trials. So what is the, I have put the bottom line. The bottom line was there was no survival benefit. Okay. And this was done in 2014. That time itself, they are downgraded. If you have seen, so there was a higher recommendation for using IABP in acute MI patients with or without cardiogenic shock. It was a class 1 or class 2 recommendation initially. But after this IABP shock 2 trial, you can see that the Kaplan-Meier curve is showing no gap between. So that means there's no mortality benefit. And there was actually much increase in incidence of some adverse events as well. So that is when they downgraded it from class 1 or class 2 in A, class 1A recommendation, they downgraded to class 3 recommendation. What does the class 3 means? Class 3 means the risk is more than the benefit. So that is what is the recommendation currently. So there's not much of a risk or some adverse events are more when you're using IABP. That is what it is. So another study, so balloon pump assisted coronary intervention study called BCIS. So this is the study. So they saw any patient with going to PCI, any high risk patient going for primary coronary intervention, they wanted to put IABP and see what will be the effect. This study also showed that with IABP, without IABP, IABP was not much of an help. So there is no role for prophylactic use of IABP. So, I mean, you need not start IABP on a high risk primary coronary intervention, assuming it will help. But they saw that in this particular study, there was no evidence at all. So starting a patient on IABP, then doing PCI, or just going ahead with PCI does not make a difference. So that means this study said there is no need for prophylactic IABP in any patients with high risk PCI. Okay. Another large study which was recently published in your Journal of American Cardiology. So this is the study. So what was the study done? It was a very small study. So where they looked into standard care, that is routine care, and with IABP care for any patient with cardiogenic shock. So and in heart failure due to cardiogenic shock, they saw what is the effect of IABP. And in this, they said standard of care alone is adequate. So there's, you can see again in the Kaplan-Meier curve, there is no gap between the waveforms. So there is no mortality benefit. They said even standard of care alone is adequate. No need to go for any mechanical circulatory support devices. So IABP did not have any benefit. Okay. And last one, so there's something called Protect 2 trial. It's an RCT. So they were mainly looking into the adverse events. So they compared 2 circulatory devices. One is your IABP and the other one is your Impella. The problem here they saw is your IABP had more adverse events. Okay, and you saw the mortality was little higher. Sorry, the adverse events were higher. This Kaplan-Meier curve is about the adverse events. So they saw IABP had very high complication rates or adverse event rates compared to Impella. So they said Impella is much better than your IABP. The adverse events, not only about help in cardiogenic shock, the adverse events rates were also very high in your IABP patients. So these are other studies. I'm not going to detail of it. So you should know the name of the studies and what is the outcome. So conclusion is none of the studies showed any benefit with IABP. Okay, there is no mortality benefit. Few studies showed there was some significant amount of adverse events, but finally all studies till now there were no mortality benefit. So if you don't remember the studies, you should remember IABP shock 1 and shock 2 trial. If you don't remember the other studies, it is still fine, but those two studies should be noted and there is no mortality benefit. Okay. Now coming to, again, whenever there's some recommendation, they usually ask you about the guidelines. I told you in 2014 itself, it was downsized in the European Society of Cardiology. So these are the guidelines. What do the guidelines say? Usually they ask you about European guidelines, but this is the overall guidelines about IABP. The latest one is from ACC-AHA. It is in 2025. So in the management of acute MI, routine use of IABP in cardiogenic shock has been, again, I told you, it was a better recommendation. I think it was class 2 previously. Now they made it class 3 recommendation. That means it is not effective and may be potentially harmful. That is a recommendation for this. Similar guidelines, similar recommendations from North American Society or the European Cardiology Society also. The latest guidelines from European Society of Cardiology was in 2017. I told you after the IABP shock 2 trial, and they have downgraded it to class 3 recommendation. Okay. So let us go into a few more serious questions. So we saw the technical aspect, we saw the console, we saw the various parameters, how to adjust, how to read and all. And we saw the common CBS questions, which is about your timing of the IABP. We saw a little about evidence. We saw the guidelines. Now the common CBS questions. I want this to be very, very interactive because last few slides, I'll have some 7 questions. So with the 7 questions, I'll be finishing this. So if you make it interactive, because this is no real exam, so you can make some errors here. So if you make some errors, you'll remember in your real exam. Okay. So let us see these questions. So the first question. So I've not made the questions big. Okay, because of the time constraint. So I kept it very, very small. You don't get so small questions in your CBS in your real exams. So I kept it small only because of the time constraint, because we have 4 topics to be discussed. So I kept it very small. So I can put a big case. You'll have a case study. So this is a patient who's on so and so, so and so. So later on, the main point will be the catheter shows presence of blood. So what is the diagnosis? How do you manage? I'll see if somebody's answered. So suddenly you see that IABP balloon shows some blood. Yes, many of you have said it right. So it is rupture of the balloon. So that is what you see. So the answer is correct. So somebody said it is removed. No, there is rupture of the balloon. So what do you do? So correct diagnosis is rupture of the balloon. Because the balloon is ruptured, the blood starts entering the catheter, and you can see that the tubing of the IABP will also have blood. So how do you manage? Anybody? Remove or replace. Very good. So that is what it is. So change the catheter. So at the same time, you should be worried about embolism also, correct? Helium embolism is also a thing. First, you stop the console. You should not push further helium into it. So suggest balloon rupture or helium embolism, one of them. So immediate cessation of counterpressure. That's what I told you. First thing you do is stop the IABP machine. So it should not push further helium inside. So placement of the patient head down. Why head down? We all know air embolism. That is the common thing we do. Put the patient head down and IABP removal, and consider giving broad spectrum. Why? Though the outside of the balloon is sterile, but the inside of the balloon is not sterile, and gas chamber is not sterile. So there is a chance of infection. So your complete answer would be stop the machine. So put the patient in head down position, remove the IABP. If the patient requires support, insert a new one. And in the meanwhile, also start him on some antibiotics because this is unsterile. This was the first question. So next, coming the second question. So again, you'll have a big history about the patient. I've not put the history because of the time constraint. So you'll have and ultimately the question would be, patient IABP, the console, produces a falling alarm. You see a falling alarm. So augmentation is below the limit set. Like how you get ventilator alarms, like ventilator tidal volume is below the limit set, or minute ventilation below the limit set. Here also you can get an alarm. Augmentation below the limit set. Why do you get that alarm and what do you do? So I'll see what are the answers. Somebody says it is timing error. Check the helium level. Okay, next. Anybody else? Delayed inflation. So it is usually the alarm limits. One of the common things can be, so the alarms may be set abnormally. Either augmentation is set too high, you have expected too high, or there has been change in patient's hemodynamics. Suddenly the patient had some issue. So suddenly some acute thrombosis has happened, or new ischemia is happening. The heart function became less. So that is when you'll get this augmentation below set limit. You can understand this. Augmentation below the limit. So you say there was significant augmentation happening. Now you see that the augmentation not happening. Either the underlying heart itself, the only reason if the machine is not having problem, the only reason is the heart function is gone down. So either you can suspect a new MI happening in your patient. Okay. So there was a significant augmentation happening. Suddenly you see that the augmentation not happening like it was happening before. That means either there's a machine problem or the heart has some problem. So one of the things you should adjust, you should address both of them. So if the heart is an issue, first you check the machine. If there's no machine problem, then that means that the patient's heart is going down or functioning is bad. So you should support it. Either you add a inotropic or a vasotropic agent and improves the performance of the heart. So next, again, you have a history and then the patient IABP, suddenly there's an alarm on the console saying no trigger alarm. What does this mean? How do you manage? So there is no trigger. Suddenly you see that the machine is producing an alarm saying, okay, sorry, I got the answer. So what is happening here? So we'll still see what the answers are. Patient is moving, change the triggers, correct. So if it comes, the management is to change the trigger. So that means either the ECG lead should have come out. So whatever is the trigger, so asystole is correct. Yes. Best thing is, if you don't know anything, change to auto mode or you can change the triggers. Yes. I think most of you have answered this rightly. Change to auto mode is the best part. Yes. If you have auto mode, yes. Otherwise, you can change the trigger. Say ECG was there, so it is not functioning. Suddenly your patient had AF, change to AF mode or change a different trigger. That's what I'm trying to tell. So next question. So patient on IBP support doing good, suddenly has a cardiac arrest. So what do you do? This question I think you should answer. Has a cardiac arrest, what do you do? And next question, part of the question was, what do you do about IABP during defibrillation? So should I switch off the IABP, keep the IABP? What do I do? So somebody said, yes, correct. Put onto auto mode. You can change to a pressure trigger. Very good. Auto mode is the safest answer. So what about defibrillation? I think first question, most of you have answered it correct. Put onto auto mode, a pressure trigger is absolutely right. So what about the IABP during defibrillation? Should I stop the IABP and defibrillate or go ahead with defibrillation or change the current, change the position? Anything about defibrillation? Continue defibrillation, go ahead. So yes, that's the right answer. Go ahead with defibrillation. No need to do anything with the IABP. Leave it like that. And you can go ahead with the regular defibrillation. Absolutely right. I think many of you are answering it also. So ECG trigger becomes dysfunctional. I told you there is no waveform coming, so it will become dysfunctional. So change it to pressure trigger or put it to auto mode. So whatever it is. So defibrillation can be safely performed with the IABP device functioning. So no need to stop or change anything on the IABP. You can completely go ahead with your IABP, with your defibrillation as you do it routinely. Okay. Next comes the fifth question. So patient on IABP support was doing fine. Suddenly patient developed tachydysrhythmia. So some abnormal tachyrhythmia happens. The IABP starts producing an alarm and hemodynamics become unstable. So what do you do now? I've already discussed this in the theory part. So what do you do now? So already have some 3 answers. Put on auto mode, change the trigger. Yes. What trigger you want to change? Auto mode, yes. Anybody else? Any other specific trigger you want to put to? Pressure trigger, auto mode, defibrillator, pressure trigger, auto mode, yes. Okay. AF trigger, yes. So you can put to AF trigger. So tachyarrhythmia up to 110 beats, usually the IABP will perform well, but only when it goes beyond 110, that is when it becomes very difficult for the IABP to get properly triggered. So there are some newer IABP machines, which will work good even up to 220 beats per minute. So that is there. Or as I told you, can change it to AF trigger. And you can see, and primarily you can't do anything about the IABP. Only management is you should correct the underlying tachydysrhythmia. So start him on some antiarrhythmics or things like that. So that is what will be helping it ultimately. But for the IABP to continue to function, you change the trigger to AF trigger or put on auto mode and treat the underlying tachydysrhythmia. Okay. Last 2 questions. So another question, patient on IABP, suddenly there is shutdown of the console. So what do you do? Suddenly you see there's power cut or the battery goes off. What do you do? Yeah, somebody said mode in cardiac arrest. That is for the previous question. So what? Suddenly the machine goes off. So this can also be asked in your... Yes, anybody? So what do you do when the machine goes off? So battery is, when you thought it is on a UPS, deflate the balloon, restart the machine. How do you restart the machine if it's some So that's what if battery is also gone. So machine is complete shutdown. It is not starting. What do? They say deflate the balloon. Anybody else? Inotropes. Correct. I mean, cardiac support you do. What do you do with the machine was the question. Increase vasopressor. So that's what you'll maintain. I mean, medically, whatever is possible, you'll be doing. Change the machine. Yes. So that will all take some time. In the meanwhile, what you're supposed to do is you will manually inflate and deflate the balloon. How do I do it? You can take a 60 cc syringe and based on what is the size of your balloon, you can inflate and deflate. This is not to support the heart. This is only to keep the balloon inflate and deflate so that it doesn't get clotted. Because we know if we leave the balloon there, it'll be prothrombotic, it'll clot, and that clot can get embolized and you'll have complications later on. You'll do it manually using a 60 ml syringe, but that your intention is not to support the heart. It is not for cardiac support, but is only to keep the balloon moving so that it will not allow any clot to form. Okay, so this is another answer. And I think last question, again, I told you about the complications. They'll definitely be asking you the questions in any intervention you do. You will definitely get a question on the complications. So I put a small case history here. You'll not get so small case histories in your real exam. So somebody said any role of extra anticoagulation you can give, but already there is a significant amount of anticoagulation, more than anticoagulation, because we all know, right? So even if you give anticoagulation, if the balloon is sitting there, a foreign body is sitting there, definitely it will lead to thrombosis. So you can give a further anticoagulation if the risk of bleeding is less, but ultimately you should make the balloon move. Before you get another machine, you can do it manually. Okay. Yeah, before reading the next question, already I get some answers. So complications. So you get a question on complications. 56-year-old male patient on ABP for cardiogenic shock. Suddenly the sister comes to you saying the pulse oximeter on the left hand is not showing a reading. What is your diagnosis? I'll read the answers. Catheter displacement, do a chest X-ray, reposition it, correct. It should be at the level of the carina. Answer, absolutely fine. I mean, you're all experts now. So yes, do a chest X-ray, confirm the position. So that is not alone the answer. One malposition everybody says. The other possibility is there can be a thrombus. Correct. That is another answer. Okay. You first answer is definitely malposition. That is what you'll be thinking. So next answer is you should think about any thrombosis happening should also be taken care of. Mainly we are looking into something occluding the left subclavian. Either it can be the balloon because of malpositioning, or it can be a thrombus which is formed because the balloon is sitting there for a long time. Okay. These two are the answers you can expect. So that's the end of my talk. And as I told you, you'll definitely get, because last few exams we have been seeing, you definitely get a question on IABP. Even if could not get time to revise, you get confused, the image is not clear, don't panic. Read the entire question, because I saw one of the questions, did not ask anything about the physiology of IABP or anything like that. They just asked, what is the augmentation on the console? I think that is the simplest thing you can answer. So you don't need to panic seeing a question on IABP, even if you're not prepared well about it. So don't panic, read the entire question. At the end of the question, it will be very simple, like I told you. So last time they asked, what is the augmentation on the monitor? They did not ask about physiology of the monitor. They did not ask what is happening in the waveform. They just asked, what is the level of augmentation? The answer was 1:1 augmentation. That's all it was. So simple. So no need to panic. Okay.